السلام عليكم اساتذتنا وزمايلنا. Our today topic is surgical management of abdominal and pelvic neuroblastoma, and I would like to thank the organizing committee for giving me the opportunity to talk about this favorable topic. Today agenda, I will try to cover the following points: the epidemiology and pathology of the neuroblastoma, staging system of neuroblastoma, diagnosis, neonatal neuroblastoma, medical management of neuroblastoma, and lastly, the surgical management of neuroblastoma. To start with, as regards the epidemiology of the neuroblastoma, it is the most common extracranial solid tumor of childhood and represents about 7% of childhood cancer and 15% of childhood cancer deaths. As regards age, the ideal age of diagnosis is below 18 years of age. As above 18 years of age, the prognosis is bad as the disease is more advanced. And unfortunately, the median age of diagnosis is 2.2 years, and most cases are diagnosed by the age of 5 years, and rare diagnosed by the age of 10 years. An important question to answer is why it is different from other tumors. Why neuroblastoma is different from other tumors? The presentation of neuroblastoma vary depending on the primary sites of origin. As we know, it may arise from the neck, from the posterior mediastinum, from the abdomen, from the pelvis. So it has a variety of presentations, and it depends also upon the metastatic burden of the tumor, and it secretes, as we know, metabolically active byproducts. Here is an important difference point which differentiate neuroblastoma from other surgical tumors which we encounter, is that the surgical capsule here can be violated. As we all know, in tumors like Wilms tumors, we have to respect the tumors, and every oncological surgeons know that whenever tackling the tumor, there must be sticking to surgical principles of removing the tumor within its surgical capsule. However, in cases of neuroblastoma, the surgical capsule can be violated, and good outcome might be achieved even if residual tumors is left behind. And outcome is significantly relying on the biology of the tumor rather than the extent of resection, as we will mention later on. The sites of neuroblastoma, it can arise anywhere along the sympathetic chain from the neck down to the posterior mediastinum, the retroperitoneum, and the adrenal, and down to the pelvis. The histology of the tumor varies from undifferentiated small blue round cells of neuroblastoma, which is further subclassified into undifferentiated, poorly differentiated, and differentiated tumors, to intermediately differentiating tumors, which is called ganglioneuroblastoma, to the highly differentiated tumors, which is a benign ganglioneuroma. Neuroblastoma both histology and behavior is heterogeneous, and thus it is unpredictable. And most have a chromosomal abnormality, which is deletion or loss of heterogeneity of 1p, 11q, and 14q in 50% of the patients, and the other 50% of the patients has a gain of 17q trisomy. And hyperdiploidy has a better prognosis than diploidy as regards the pathophysiology, and 30% of patients with neuroblastoma has MYC-N oncogene amplification, which is associated with advanced disease at presentation and worse outcome. I try to entail some MCQ inside my presentations in order to make the presentation somewhat interactive. And the first MCQ is, in counseling the family of a child with neuroblastoma, what is the single most significant determinant of poor prognosis? Is it the age, or serum ferritin, or incomplete surgical resection, or MYC-N amplification, or tumor ploidy? I think Dr. Mohammed Saada has polling for this question. In counseling the family of a child with neuroblastoma, the single most significant determinant of poor prognosis is.
دكتور احمد حضرتك شايف البول؟
ايوه دكتور محمد.
تمام.
I think that the majority of our colleagues have answered these questions right, which is the MYC-N amplification. The presence of more than 10 copies of MYC-N amplification carry the worst prognosis, regardless than other factors such as the age or tumor ploidy or even the extent of surgical resection. And this is a very important point to take in mind. Okay, so we resume in our presentation. Coming to the staging of neuroblastoma, the staging for neuroblastoma is some bit confusing. At least 6 different staging systems for neuroblastoma exist. The most uniform staging system and most popular is the International Neuroblastoma Staging System, which is the INSS, and it is clinical, radiological, biological, and surgical staging. This is a bit busy slide. I wouldn't bother you with all these informations. Mainly the INS tumor staging relies upon surgical resections. To do INS staging of the neuroblastoma, the patient must have surgical resection first to know whether it is a tumor with complete growth excision or incomplete growth excision. It is covering the midline or metastatic. So in order to reach staging by INSS, the patient has to undergo surgery first. Historically, there is a disparity between the classification or the staging system between the United States and Europe. This is the old way of classification. The SIPEN in Europe depends upon age, make-in status, and the surgical risk factors, which is the resectability. In United States, they add the tumor histology and the DNA index and tumor ploidy, and this was the old way of classification or staging of neuroblastoma. However, recently, since 2009, and since it was rapidly popularized, something called International Neuroblastoma Risk Group Staging System. And this is based on something called image-defined risk factors, which I will elaborate on later on. It makes the classification a bit easier, and it doesn't need that the patients undergo surgery before classification. It's divided into 4 stages: L1, L2, M, and MS. L1 is localized tumor, localized into one anatomical region, either the thorax, the abdomen, or the pelvis, without image-defined risk factors, and I will elaborate on this later on. L2, it is a local regional tumor with one or more image-defined risk factor. Stage M is a distant metastatic disease except MS, and MS, it is a child below 18 months of age, and INRG stage L1 or L2 tumor with metastatic disease confined to the skin or the liver or bone marrow, and the involvement of the bone marrow must be less than 10%. Here is the image-defined risk factor. What is the image-defined risk factor? In order to know the INRG, we must know what is meant by image-defined risk factors. They are surgical risk factors identified preoperatively by imaging at diagnosis before any treatments for the patient, and they are based on radiological criteria, and they allow consistent and uniforming reporting and act as a warning for the surgeon and the prognostic factor for surgical complexity. However, it is very important that IGRF, image-defined risk factors, are not considered as a contraindication to perform surgery in patients with high-risk neuroblastoma. The image-defined risk factors descriptions is according to the anatomical regions, whether it is in the neck, in the cervical region, the thorax, or the abdomen. What concerns us is the abdomen and pelvis, and these are the criteria of the image-defined risk factor in the abdomen or the pelvis: the tumors infiltrating the porta hepatis or hepatoduodenal ligaments, tumor encasing branches of the superior mesenteric artery or the origin of the celiac axis, or invading one or post-renal pedicles encasing the aorta or the vena cava or the iliac vessels, and pelvic tumor crossing the sciatic notch. Here is an illustration to show what is meant by image-defined risk factors. This is a neuroblastoma tumor, and this is the artery, and this is the vein. You can see this. Whenever the tumor comes in contact with the circumference of the artery with less than 50% of the circumference of the artery is in contact with the tumor, this is just called contact, and this is not considered image-defined risk factor. We see here the artery in axial section and longitudinal section, and the relationship between the tumor and the artery is less than 50% circumference involvement, so there is no image-defined risk factor in this. As regards vein, the flattening of the vein with a visible lumen for the vein is considered no image-defined risk factors. As we notice here in these images, this is the neuroblastoma and this is the artery. There is more than 50% of the circumference of the artery in contact with the tumor, so this is a partial encasement, and this is considered image-defined risk factor. Again, there is a total encasement here of the artery within the tumor of the neuroblastoma, so this is called image-defined risk factor. And for the vein, there is a flattening with no visible lumen. Whenever there is a flattening of the vein with no visible lumen, this is considered an image-defined risk factor. This is an example of a patient with neuroblastoma on the left side. As we see here, this is a neuroblastoma on the left side. This is displacement of the left kidney with no infiltration. And this arrow shows the aorta. There is a contact between the neuroblastoma and the aorta with less than 50% of the circumference involvement. This means there is a contact and no image-defined risk factor. Again, here is the aorta in the coronal section, maximum intensity projection, and this is the left renal artery and the displacement of the left kidney. Again, there is less than 50% involvement of the circumference of the aorta and the left renal vein. So this show a case of neuroblastoma with no image-defined risk factor L1 INRG. This is another case of neuroblastoma, a median neuroblastoma with involvement of the central structures in the abdomen arising from the left side, and here is displacement of the left kidney. This is a neuroblastoma. As we see here, the aorta and the celiac trunk, and the celiac trunk here branches into the hepatic and the splenic, and there is encasement of 100% of the circumference of the aorta, the celiac, the hepatic, and the splenic. So there is here an image-defined risk factor. Again, here is bilateral renal artery are involved within the engulfed or encased within the neuroblastoma. So this represents a case of neuroblastoma with image-defined risk factor. As regards histology of the neuroblastoma, it is a round blue cell tumor, and it is large numbers of cases of differential diagnosis for round blue cell tumors, including Wilms tumor, Ewing sarcoma. It is a mixed tumor histology with immature and mature elements. It is divided into favorable histology, which is stroma-rich and have Schwannonian stroma, neuroblast differentiation, nuclear and cytoplasmic features of ganglion cell, and unfavorable histology with stroma-poor and immature undifferentiated neural cells, high mitotic karyorrhexis index, MKI. This is the new way of classification, which is the INRG, International Neuroblastoma Risk Group Classification System, and it depends upon 7 clinical and biological criteria to stratify the patients into 4 groups: very low, low, intermediate, and high. The 7 criteria are the INRG stage, the age of the patients, histological category, grade of the tumor, MIC-N status, living Q aberration, and the ploid of the tumor. As we have mentioned, the INRG is L1, L2, M, and MS. Age of the patients less than 18 months of age have favorable prognosis, and those above 18 years of age have poor prognosis. Histological category, as we have just mentioned, there is a stroma poor and stroma rich. Those with stroma rich are better favorable histological prognosis, and stroma poor carry a poor prognosis. And the grade of differentiation, whether it is undifferentiated, poorly differentiated, or good differentiations. And of course, as we have mentioned before, the presence of the MIC-N amplification carries the worst prognostic parameters of cases of neuroblastoma. And again, living Q aberration carry a worse prognosis. And ploidy, as we have mentioned also before, hyperploidy is far worse prognosis than diploidy or aneuploidy. So we have 4 risk group stratification: very low and low, intermediate, and high. And unfortunately, the high risk group represents about 36% of the cases of neuroblastoma which we encounter. And the event-free survival range from more than 85% in the very low and low risk group to less than 50% in the high risk group of neuroblastoma. Presentation of neuroblastoma. Here comes the second MCQ. This is a child, an 8-month-old boy with failure to thrive and suspicious of non-accidental trauma, who is admitted to the emergency room. The next step in this child is to transfer to trauma center for complete evaluation, head CT, abdominal CT, coagulopathy workup, or ophthalmology consultation. Again, as I noticed, most of our colleagues here answered the right answer, which is abdominal CT. You have to bear in mind that this is called the raccoon eye. And the raccoon eye in a child, in the absence of history of trauma or accidents or something like this, you have to think about orbital bleeding or something like retroorbital neuroblastoma, especially in a child young age less than 1.5 years. As we have mentioned before, neuroblastoma can arise anywhere along the sympathetic chain from the neck down to the thorax, the abdomen, and the pelvis. The incidence of cervical neuroblastoma is 1%, and thoracic neuroblastoma or posterior mediastinal is 20%. Retroperitoneal neuroblastoma of the adrenal medulla represents the highest incidence, which is 50%. And by the way, it carries a worst prognosis among any neuroblastoma from primary sites. And neuroblastoma of paraspinal retroperitoneal origins, and the pelvic neuroblastoma represents 4%. So abdominal neuroblastoma represents about 25 and 50, about 75% of the cases encountered, and minority of cases are pelvic neuroblastoma, which represents less than 5%. About the presentation of neuroblastoma, usually in an unwell child who has non-specific manifestations of fever, malaise, and pain. The presence of abdominal neuroblastoma of large size presents mainly with emesis, constipation, and intestinal obstruction. And presence of a pelvic neuroblastoma of large size may be presented with lower extremity edema due to the impairment of the venous and lymphatic drainage. Cervical or thoracic neuroblastoma may be presented by Horner syndrome. And for those who are not familiar with Horner syndrome, it is ptosis, meiosis, inophthalmos, or anhidrosis, or superior vena cava compression syndrome due to the compression of the superior vena cava. The presence of the abdominal retroperitoneal paraspinal lymph nodes or neuroblastoma is presented mainly by back pain, extremity weakness, and bladder dysfunction. Neuroblastoma metastasize to various organs or various parts of the body, among which is important lymph nodes and bone marrow, bone cortex, dura, orbit, and liver and skin. Involvement of the bone marrow and bone cortex is mainly manifested by bone pain, anemia, and bleeding diathesis. As we mentioned, orbit involvement is presented mainly by periorbital ecchymosis, raccoon eye, and proptosis due to the presence of the retropulbar metastasis from neuroblastoma. Liver involvements by bulky metastasis lead to hepatomegaly and sometimes respiratory distress and abdominal compartment syndrome from heavy deposits in the liver with renal failure and bleeding diathesis. And involvement of the skin presented by something called blueberry muffin skin, which subcutaneous nodules, erythematous, bluish, reddish in color, and non-tender. The third MCQ, the mode of metastasis spreads in neuroblastoma is hematogenous, lymphatic, cerebrospinal, 1 and 2, 1 and 2 and 3. I think the correct answer here is 5, 1 and 2 and 3. The mode of metastasis in neuroblastoma is through hematogenous, lymphatic, and cerebrospinal fluids. So both three routes of metastatic spreads are present in neuroblastoma. Among other manifestations of neuroblastoma, something called paraneoplastic syndrome. Two features of paraneoplastic syndromes is the obsoclonus myoclonus ataxia, and it is a sort of antigen antibody complex due to antibodies generated inside the body against the antigen of the tumor, which cross-react with the Purkinje fibers in the cerebellum, causing obsoclonus, which is dancing eye movements, myoclonus, which is rhythmic jerking, and ataxia, and presence in 1 to 3% of the children with neuroblastoma who have obsoclonus myoclonus ataxia. Another manifestation of the paraneoplastic syndrome is diarrhea due to the secretion of the vasoactive intestinal peptide, which tumor usually have somatostatin receptors, and usually this occur in differentiated low-risk tumors and associated with hypokalemia. For the diagnosis of the neuroblastoma, we rely upon lab and imaging criteria. For lab, in the serum, we do something called neuron-specific enolase, ferritin, and lactate dehydrogenase. And none of these are specific for neuroblastoma. But once diagnosis of neuroblastoma is established, these three factors are used for monitoring the response to treatments. And you can search for catecholamines in urine, vanillin mandelic acids and homovanillic acids, which is present in more than 95% of cases of neuroblastoma, and also used to monitor response for treatments. As regard imaging, as we know, to start with in pediatric population, we start usually with ultrasound as it is minimally invasive, cost effective, and doesn't include radiation exposure. However, in neuroblastoma, it has low sensitivity and low accuracy, and the abnormal finding should prompt you to proceed to cross-sectional imaging. The cross-sectional imaging we use is CT or MRI is used for the initial or establishing the diagnosis of the neuroblastoma, and of course in the preoperative planning and after treatments to monitor for response of treatments and recurrence. And we as surgeons are more familiar with CT rather than MRI. However, MRI can have the advantage over CT in better visualization of the vascular structures and the intraspinal and neural involvement of the neuroblastoma, especially in tumors extending the dumbbell tumor, which is extending inside the spinal canal. PET-CT is not primary evaluation tool and is used mainly in discordance finding on MIBG scan. This is an example of CT patients with left neuroblastoma, and as we see here, there is patchy calcification in a large neuroblastoma on the left side. And MIBG scan, this is the most sensitive for bone marrow involvements. MIBG is a norepinephrine analog, which is uptaken and stored inside the tumor tissue and used for evaluation of the bone involvement. 90% of the patients are positive for MIBG. However, in 10% which are not MIBG avid, we use MDP for bone scintigraphy. And if the bone scan we use if the tumor is surgically removed. For establishing tissue diagnosis, we do bilateral iliac crest bone marrow aspiration plus or minus biopsy. If the bone marrow biopsy is inadequate, we may resort to biopsy of other sites of the tumor. Biopsy of the tumor is either by open surgery or keyhole surgery like laparoscopic or thoracoscopic, especially in cases of posterior mediastinal tumors. We use the thoracoscopic biopsy, or by needle core biopsy using ultrasound or CT guided biopsy. The entity of the prenatal neuroblastoma. First, we have also MCQ4. Initial management of newborn with 2 centimeter solid adrenal mass and negative metastatic workup will go by observation, chemotherapy, biopsy of the tumor, resection of the mass, resection of the mass if only MIBG negative. The correct answer here is number 1, is observation. Management of newborn with 2 centimeter solid adrenal mass and negative metastatic workup is observation. And I will mention why in the next few slides. The prenatal diagnosis of neuroblastoma is usually by ultrasound, which is found after 32 weeks of gestation and is early detected by the 20 week. And most of the cases of the prenatal diagnosis have favorable biology. They have 3 morphology: purely solid or purely cystic or partially cystic and partially solid. For postnatal diagnosis, we do as we do in older children, we repeat abdominal ultrasound, then proceed to cross-sectional imaging such as CT or MRI, and do lab tests such as CBC or lactate dehydrogenase and urinary catecholamines. And MIBG scan is indicated only if the mass is more than 1 centimeter or there is elevated urinary catecholamine. Mainly, we resort to observation of these cases of neonatal neuroblastoma if it is a solid adrenal tumor less than 3 centimeter, or it is a cystic tumor less than 5 centimeter, or INRG L1 and the child is less than 6 months of age. And in a study by the Child Oncology Group, they prospectively studied the expectant observation of patients with neonatal neuroblastoma by extensive follow-up protocol using abdominal ultrasound and urine catecholamines every 3 weeks, and abdominal CT and MRI at 0, 6, and 42 weeks. They reached 3-year event-free survival for neuroblastoma of more than 95% and the 3-year overall survival of 100%, and 81% of the observed patients spared resection. However, there is a rigid criteria for surgical resection of neonatal neuroblastoma whenever there is a 50% increase in the tumor size or 50% increase in urinary catecholamines, or catecholamines don't return to baseline within 12 weeks. Very briefly, I will cover the medical management of neuroblastoma to go after that to the surgical management in details. As we know, to start with, we start by induction chemotherapy in patients starting from L2 stage to reduce the tumor burden at the primary site and the systemic disease. Chemotherapeutic agents used are the platinum analog, anthracycline, alkylating agents, and epibodophylotoxins. Myeloablative chemotherapy is mainly used in a high dose with stem cell rescue after the tumor debulking by chemotherapy and surgery to eradicate surviving tumor cells. And it has significant improvements in event-free survival, not overall survival, compared with non-myeloablative chemotherapy. So the use of the myeloablative therapy, it improves the event-free survival and not overall survival. 13 cis-retinoic acids, as we know that 50% of the high-risk neuroblastoma will relapse even after clinical remission. So we use the retinoic acids for maintenance therapy and the treatments of the minimal residual disease, as it improves both event-free survival and overall survival in patients with neuroblastoma. Immunotherapy, the most promising agent is something called GD2, and it also improves 2-year event-free survival and overall survival, especially when combined with interleukins 2. For radiotherapy in neuroblastoma, it is part of high-risk protocol. And as we know that neuroblastoma is radiosensitive, so we use this of radiotherapy after surgical resection of the primary tumor and local control in unresectable tumor and progressive tumors unresponsive to chemotherapy. Again, life-threatening complications associated with chemotherapy, bulky metastatic disease, and palliative therapy are all indications of use of radiotherapy for patients with neuroblastoma. Lastly, MIBG therapy is effective in disease palliation, and it produces good response in 18 to 37% of the patients with refractory or relapsed disease and used in combination with radiosensitizing chemotherapy. Coming to surgical management, which is the main bulk of this presentation. Surgical management is tailored according to the INRG staging. For patients with L1, meaning that patients with localized disease confined to one compartment with no image-defined risk factors, complete surgical resection is the mainstay of treatment, and it is a definitive therapy. Patients will not need for induction chemotherapy, and this patient has excellent outcome, and even biopsy is unnecessary if the tumor is easily resectable and the metastatic workup is negative. Patients with image-defined risk factors L2, biopsy of the tumor or the bone marrow biopsy for staging, vascular access device placements for the induction chemotherapy, tumor resection after 4 cycles of induction chemotherapy, and usually we don't add more than 4 cycles of chemotherapy, as tumor shrinkage will not be expected to happen after the 4th cycle, and it will not add any additive benefits to the patients besides increase the risk or side effects of chemotherapy. It improves resectability and it minimizes complications of the intraoperative and post-operative resections. Upfront resection is not recommended and may not be possible in patients with L2 stage. It increases surgical complication and is not associated with any significant improvements in event-free survival or overall survival. In patients with M stage, more than 80% of the patients older than 1 year have metastatic involvement of the bone marrow. Most are diagnosed with bone marrow aspirate or biopsy. Surgical biopsy is only resorted to if the bone marrow aspirate or the biopsy is negative, or if tumor histopathology need additional clarification. Again, insertion of vascular access device for the induction chemotherapy before definitive surgical resection of the primary tumor and metastatic disease. For patients with MS, usually those patients don't need surgery, just supportive therapy, most spontaneously regress and have a good prognosis. However, surgery is often required for complications such as abdominal compartmental syndrome or respiratory insufficiency. This is the last MCQ in our presentation today. Management of spinal cord compression in a child with abdominal neuroblastoma and lower extremity weakness. What is the best treatment option? Immediate primary tumor resection with anterior decompression of the spine, immediate laminectomy, and posterior cord decompression, high dose dexamethasone for 3 days and repeat imaging, high dose dexamethasone and emergency radiotherapy, high dose dexamethasone and systemic chemotherapy. I think the correct answer for this question is number 5, high dose dexamethasone and systemic chemotherapy. And I will mention this later on, the explanation of this. Okay. Let's continue with our presentation. Emergence operative intervention is needed in some situations such as abdominal compartmental syndrome. Abdominal compartment syndrome occurs whenever there is heavy deposits in the liver with hepatomegaly, which elevation of the diaphragm and causes respiratory compromise and renal dysfunction. We do a laparotomy and relieve the abdominal compartment syndrome in such cases. And in cases of the paraspinal tumors with extension inside the intraspinal canal with neurological symptoms, here we may resort to laminotomy to reduce the cord compression. However, it has a severe long-term sequelae. So surgical resection, either laminotomy or laminectomy in the past, carry a severe long-term sequelae and complications. And nowadays we resort to use high-dose dexamethasone together with induction chemotherapy to reduce the burden of the tumor, which compress the spinal cord and cause neurological symptoms. Some surgical technical tips as regards the surgery of neuroblastoma. First of all, a thorough analysis of the preoperative CT and MRI should be performed with our radiologists. We should do multiple revision of the CT and MRI preoperatively to study well the vascular anatomy and the relation of the tumor to surrounding structures and the local extension of the tumors, and identify every vascular branch arising from the major vascular vessels, aorta, and IVC. Neuroblastoma surgery is a big operation. It is one of the most major operations we do in pediatric urology. We start by endless review of the scan with our colleagues in the radiology, and always try to use the same surgical approach you are accustomed to. The anesthetist is very important to have good communication with, and also the theater team, the assistants, the strap nurse. All these are very important and critical because it is a lengthy operation. It requires long time. It requires cooperation between the theater team and your colleagues. And very importantly, the night before the operation, you have a good night's sleep. No distractions in the morning. This is the fields we encounter, and we see how complex will be the tumors. This is the sympathetic chain around the main vessels, which is aorta and IVC, and this is the retroperitoneum and bilateral renal pedicles. And as we see here, the aorta and IVC and the sympathetic chain on both sides of these major vessels. It's very important to stick to surgical principles here to allow a good operation and avoid complication intraoperatively. First, you have to define the compartments. You have to define in which compartments you work the extension of the tumor, either in the thorax, and the abdomen, in the pelvis. And important to achieve a very good exposure. In these operations, you have to good exposure. You have to see what's in. You have to expose all the retroperitoneum, both renal pedicles on both sides, and define the anatomy. Because sometimes the anatomy is distorted, the organ is displaced, and most importantly, establish something called subadventitial plane of dissection, as I will discuss later on. This is a field we see in the retroperitoneum. For retroperitoneal neuroblastoma, our approach is one of these following approaches is thoracoabdominal approach or bilateral subcostal or transverse upper abdominal incision or midline incision. The thoracoabdominal approach has the advantage that it has superior exposure for complete extirpation of the thoracoabdominal aorta, celiac trunk, superior mesenteric artery, and the renal hilum. However, the patient suffers from morbidity of the approach as you have to enter through the thorax, through the intercostal space, cut through the diaphragm. However, personally, I find that the bilateral subcostal, which is a chevron incision or the transverse upper abdominal incisions, also can allow access to the left and the right retroperitoneum in tumor involving central vasculatures as well as bilateral renal hilum or bilateral iliac vessels. The midline incisions can be limiting in younger children. Why? Because the transverse dimension is usually larger than the longitudinal dimensions in young kids, which may limit complete mobilization and exposure of the kidneys on both sides. This is a thoracoabdominal incision, and this is a midline incision, and this is a subcostal incision, which can be extended on the other side to be bilateral subcostal or chevron incision. Our procedure usually begins by the left mobilization of the small and large bowel along the white line of Told. Here is the transverse colon. This is the descending colon, and we begin by incision along the avascular plane here, the white line of Told, and begin by left medial mobilization of the small and large bowel, spleen, and pancreas to find the left kidney and left renal pedicle. Our general strategy, which we are going to follow during the procedure, is debulk the tumor piecemeal. We remember, as we mentioned in the early slides, that the neuroblastoma is different from other tumors that you can violate the capsule. You don't need to remove the entire specimen in one piece. In block removal of the involved vasculature or the organ is not allowed, and you try to preserve as much as you can the vital structures, especially the kidney and the major blood vessels. Again, ultrasound and scalar Doppler can be used intraoperatively to see through the encasing tumor and identify the location of these vessels through the encased tumor. For exposure inside the retroperitoneum, we start by proximal and distal control of the aorta. For proximal control of the aorta, what is called supraceliac aortic control, it begins by the left cross of the diaphragm. As we know, the aorta enters from the thorax to the abdomen through something called the median arcuate ligaments, which is formed by the right cross of the diaphragm and the left cross of the diaphragm. After incision of the hepatogastric ligament, which is the lateral omentum, we will find this picture, which is the median arcuate ligament, and the aorta enter from the thorax to the abdomen through the median arcuate ligament. We gain access to the supraceliac aorta through the left cross of the diaphragm. We have to cut here through the left cross of the diaphragm. Here is the patient's supine with the head here and the leg here. We cut through the left cross of the diaphragm to gain access to the supraceliac aorta and place a Rommel tourniquet for proximal vascular control. Don't begin with resection of the adrenal or the retroperitoneal primary tumor bulk in case of the median neuroblastoma. Of course, in cases with localized tumor, L1 tumors, in which there is no extension to the major vascular vessels, you can start by attacking the adrenal or the retroperitoneal primary tumor. But in cases of the median tumors, it's better first to have proximal and distal control of the major vascular structures, especially the aorta and the IVC. Once the left cross and the upper aorta are in view, you can easily identify the celiac trunk with its major branches, the hepatic, the splenic, and the left gastric. And just below the left cross, you can find the superior mesenteric artery, short distance distal to the celiac trunk. This is the celiac trunk, arise by right angle, and the superior mesenteric artery arise here from the aorta. Once the left cross and upper aorta are in view, you can free the aorta on the left side towards the left renal hilum. This is a technique which we use, which is called bivalving technique. Bivalving technique means incise through the mass or the burden of the tumor by finding the plane between the tumor and the adventitia of the vessels. Our favorite instruments to use during the dissection is the semi-plumb dissectors, which is Gemini clamp or gentle curved dissectors. It's not right angle clamp, it is just gentle curved clamp called Gemini clamp. And once the plane is achieved, the vessel is kept underneath the clamp, and you can bivalve the tumor by cautery to divide the parenchyma above the clamp. Keep in mind here, this is the artery, this is the intima, the media, the adventitia. The periadventitial plane here is not obliterated. You can find the plane easily by your clamp between the tumor and the adventitia, which is the periadventitial plane, which you have to follow to skeletonize the vessels and free the tumor from the encased blood vessels. But in some cases, the periadventitial plane is obliterated like this. And so one may be compelled to pursue a subadventitial plane on the vessels or the aorta. Here, we would caution this approach, as this can weaken the vessels and increase the chance of vessel ruptures or avulsion during surgery or in the post-operative period. Again, you can leave small plaques of tumor in place, no problem. You can you do something called complete gross resection. You are not going to remove 100% of the tumor. You can allow it to leave small plaques of the tumor in place, particularly on the celiac and superior mesenteric origin or distally. Special care should be taken when dissecting the tumor between the celiac trunk here, and superior mesenteric artery, because the tumor usually here abuts the uncinate process of the pancreas on the right side, as well as the superior mesenteric vein. You can easily injure both structures while removing the tumor between the celiac trunk and superior mesenteric artery. Therefore, one should avoid taking pancreatic tissue when dissecting this area of the tumor. A full cattle brush maneuver, which is right medial visceral rotation, is often required for central tumors in order to fully expose the right renal hilum and the vena cava. As we see here, this is the vena cava, and this is the right renal hilum. We do right medial visceral rotation by incising along the white line of Told along the ascending colon. And similar approach should be followed for a right suprarenal tumor with the central lymph node involvement. For the vena cava is a thin walled as compared to the aorta, so special care must be taken to extirpate the vessels from the encasing tumor. Thin lumbar veins from the IVC tend to be very fragile and split significantly if avulsed, and many of these can be ligated. Some area where there is no plane presence for bivalving and dissections, small rim of the tumors or plaque of the tumors can be left in place to prevent tearing of the IVC. Again, among important area which you try not to injure, the portahepatis disease can be left alone if it is constitute a small percentage of the tumor volume due to the risk of damage of this vital structure. The disease in the interaortocaval groove is dissected and removed in a similar piecemeal fashion. The underlying right renal artery in the aortocaval groove and the right side of the superior mesenteric artery must be identified carefully and left unharmed when dissecting in this area. This is the aorta, as we see here, and this is a bifurcation of the aorta. This is the inferior mesenteric artery. This is the left renal vein crossing the aorta, and this is the IVC. This is the aortocaval groove. We remove all tumor tissue in between the aortocaval groove piecemeal, trying to avoid injury of the right side of the superior mesenteric artery and the right renal artery. Again, aortocaval groove is very rich in lymphatics, so you have to pay attention in this area because there is high incidence of chylous ascites or chyle leak when there is injury of the lymphatic channels. So we resort to do suture ligation or hemoclips or use harmonic scalpel to seal these lymphatics to prevent chyle leakage. For the part of the aorta which is below the renal hilum, the right side of the aorta can be exposed from downward from the iliac bifurcation up to the inferior mesenteric artery up to the crossing of the left renal vein. Why we do this? Because if we notice here that this is the aorta below the renal pedicle, the inferior mesenteric artery usually arises from the left side of the aorta, and also there is dense condensation of the hypogastric plexus on the left side of the aorta. So you try to incise the periadventitial plane on the right side of the aorta, not on the midline or the left side of the aorta, to try to avoid the origins of the inferior mesenteric artery and the autonomic hypogastric plexus, which may cause persistent diarrhea or later on erectile dysfunction if injured during dissections of the aorta. So you have to shift your plane on the aorta on the right side on the right side of the aorta below the renal hilum. Again, very important tip, avoid encircling distal aorta for distal aorta control. If you want to do distal aorta control of the aorta, you have to control the aorta via the common iliac vessels. This is the right common iliac vessels. This is the left common iliac vessels. You can encircle these post common iliac vessels with a vessel loop. Don't try to encircle the distal aorta because the plane here is very adherent posteriorly and to the IVC, and there is very high incidence of injury, either the IVC or the aorta or lumbar branches from both vessels. So while dissecting the posterior to the aorta, either to the right side or the left side, lumbar arteries will be encountered, which can be ligated as needed. Coming to pelvic neuroblastoma, our approach will be lower midline incision or fenestrine incision, which will allow good exposure to an area about 1 centimeter above the symphysis pubis to give adequate exposure to the deep pelvis. And lesion originating from the aortic bifurcation can encase both the iliac arteries and vein. Iliac artery is often easily identified from the aorta and can be followed distally to down to the femoral bifurcations. However, the vein is more difficult to identify because it is posterior to the artery and usually very fragile. So dissection must be very slowly and meticulously to avoid injury to these vessels. Sometimes preoperative ureteral stent placement is needed, but is not usually required, as the ureter can be pulled proximally to this area. Ureter should be circumferentially extirpated from the tumor with a bivalving technique. Small plaques of the tumors can be left on vital structures, vessels at tightly adherent points to avoid injury. Here is an important tip: iliac artery in a younger child can go easily into space. So you have to use pulse oximetry on the leg in order to continuously monitor the distal perfusion and avoid space. And you may use topical papaverine or lidocaine for avoiding of space while dissecting on the iliac artery in young children. Dissection of the presacral space can also be performed, and one should be aware of the hypogastric plexus again in order to preserve these nerves as well as the sacral nerve for deep pelvic tumors. Don't chase the tumor in the neural foramina and leave small plaques of the tumor in this area to avoid nerve injury and leave it to post-operative chemotherapy or radiotherapy. Very important question: when do you stop? Usually we stop when patient's life at risk or there is important organ at risk, such as the kidney and bowel. It's very necessary to have a break from time to time. And we know that neuroblastoma is a very lengthy operation. Sometimes it is about 7 to 8 hours. We usually operate in teams, in pairs. Sometimes one take a rest and the other gets in, do some job and return again. It is a lengthy operation, so you need to work in teams and in pairs. For the post-operative care, the child is transferred to the pediatric ICU or high dependency units, and pain management is very important, it's very critical. It improves recovery of the patients and makes the experience less favorable for the patients and the family, of course. Complication of surgery includes bowel ischemia, chylous ascites and stylosaurus, which is an annoying complication, bleeding, hypotension, acute renal failure, prolonged ileus, and chronic diarrhea. Complication after neuroblastoma surgery range from 9 to 35%. The rate of nephrectomy up to 8%. Renal ischemia and insufficiency reach 2.5%. Operative mortality following neuroblastoma surgery is thankfully not very high, less than 1% in Cypen data, 0.7%. And the causes of mortality range from liver ischemia, bilateral renal ischemia, spinal ischemia, aortic injury, and extensive hemorrhage. This is a nice paper demonstrating that the complete surgical resection is feasible and in the improved outcome in INRG high-risk patients with localized neuroblastoma older than 18 months. Then comes the question: does aggressive surgical resection improve survival in advanced stage 3 and 4 neuroblastoma? This systemic review and meta-analysis try to answer this question, and they come to conclusion that the clear survival benefit is shown for gross total resection in stage 3 neuroblastoma only. However, in stage 4 neuroblastoma, some advantage can be demonstrated for gross total resection as regards event-free survival and not overall survival. Can we use minimal invasive surgery for neuroblastoma? Yes, there are many reports in the literature reporting the use of thoracoscopy or laparoscopy in management of neuroblastoma. However, you have to clearly select your patients. Your patients has to be low-risk patients with no image-defined risk factors and low size of the tumor less than 6 centimeters. So laparoscopic resections of neuroblastoma can be done in patients with absence image-defined risk factors, and usually we resort to use this in patients with posterior mediastinal tumors. Follow-up of the patients by close surveillance for signs and symptoms of recurrent disease by urinary catecholamines, physical examination, CT and MRI every 3 to 6 months for 2 years, because the incidence of recurrence is usually highest in the first 2 years after the operation, and patient is considered cured at 5 years of age. There is still current controversial issue as regards the topic of neuroblastoma, whether we do aggressive versus non-aggressive surgery for stage 4 high-risk neuroblastoma. What is the definition of the complete tumor resection? What is the definition of the residual tumors? There is no clinical guidelines in these definitions, but most agree that the complete tumor resection is more than 90% visually, and the residual tumors is more than 4 milliliters. What is the timing of the surgery, early versus late? And there must be consistent reporting of the operative finding. Thank you.
احمد بنشكرك يا احمد جدا على المحاضره الجميله دي وعلى الديتيلز بتاعت السيرجيكال ريكونستراكشن. الاسئله اللي جات لي وليد داوود رقم 1، دكتور احمد عبد الحليم المنصوره، ودكتور ايهاب رأفت. فانا هحاول ان انا افتح السبيكر نمره 1 لوليد.
مساء الخير يا دكتور احمد، متشكر على المحاضره الجميله ديت. انا بس كان مستفسرين بشكل كده. اول حاجه يا دكتور احمد، انت عارف ان حالات النيوروبلاستوما بالذات اللي هي الميد لاين او البايلاترال بيبقى فيها سنسيف دايسكشن وليمفوريا، والعيان ممكن يجي له كايلس اسايتس بعد كده او كايل ليك فتره طويله جدا. فلو حضرتك عندك اكسبيرينس في الموضوع دوت، ذا بيست مانجمنت فور كايل ليك اور لونج كايل ليك in case of post-operative neuroblastoma management. And the second question about the timing.
والصوت واطي شويه يا وليد، والله انا يعني مش سامع كويس. انا لوحدي ولا كله برضه مش سامع كويس؟
بص يا دكتور احمد، هو وليد بيسالك على الكايل ليكج following extensive dissection for neuroblastoma. What is your experience in the management of persistent chyle leakage?
Yes, I got this. I'm glad you asked this question, Dr. Walid, because we have encountered a couple of cases with the persistent chylous leakage and chylous ascites after surgical management of abdominal neuroblastoma. And it was a tricky situation. Usually, treatments of post-operative chyle leak follow conservative management. Low-fat diet, intermediate chain triglycerides, and sometimes total parenteral nutrition for 1 or 2 weeks may cause this leakage to cease. However, very few patients may require surgical intervention. Chylous ascites doesn't even complicate the post-operative period or retard the administration of post-operative chemotherapy or something like this. But you have to wait. Usually, we wait for 2 to 3 weeks. It decreases by time. We may resort, as I said, to low-fat diet, medium chain triglycerides, or TPN. And usually, these patients respond well upon conservative treatments.
احمد، بيتهيألي كمان انت قلت في المحاضره حاجه مهمه جدا جدا بالنسبه للكايل ليكج. which is more important than treatment is to avoid the occurrence of this chyle leakage. بصراحه it's
very critical. This is very critical. طبعا احنا during surgery try to avoid by using suture ligation and clipping any lymphatic vessels not to cause post-operative chyle leak. Avoidance is better than treatment, as we know.
واكتر مكان في الحقيقه بيحصل فيه هو the area inter aortic cavern. يعني وليد.
ايوه دكتور عايز.
اتفضل يا وليد.
بس I have a comment. Have you any experience about somatostatin use or vasopressin in such case, Dr. Ahmed, of chyle leak? And the second question about the timing of surgery after induction of chemotherapy. What's the exact time or the proper time of surgery after induction of chemotherapy? Thanks, Dr. Ahmed.
As I understand from Dr. Walid, is timing of surgery after induction chemotherapy.
Yes.
Right. As we have mentioned, induction chemotherapy, we usually give 4 cycles of induction chemotherapy before definitive primary surgical resection, because the addition of any cycles will not add additional benefits, and we try to go into the theater within the first 2 weeks after the last session of chemotherapy for 2 important reasons. First, to avoid the development of resistance clones, which develop if you will retard your surgery more than 2 weeks after the last session of chemotherapy. Second, because if you wait more time, you will have a fibrous tissue in the operative field, which will be very difficult during dissection of the tumors and will make your operations far more complicated. So the best time to go in after finish 4 cycles of induction chemotherapy within the 2 weeks after the last session of induction chemotherapy.
السلام عليكم جميعا. قبل بس ما ابتدي الساينتفك كونتنت، انا بس عايز يعني كل ما يبقى عندنا محاضرة على الجروب ده طبعا لازم نفتكر أخونا الكبير رحمة الله عليه دكتور سالم، وأنا أعتقد إن ده شيء هيفضل من الأعمال اللي ربنا سبحانه وتعالى ييسرها، يكون من الحاجات اللي تبقى تحسب له بعد ما ماتوا. فبفكركم وبفكر نفسي إنه كل ما يبقى عندنا محاضرة ندعي لأخونا المرحوم دكتور سالم خليل. نمرة 2، طبعا أنا يعني بصراحة المحاضرة في منتهى الجمال يا أحمد، حقيقي يعني ايفورت جبار، وأنا طول عمر الزملاء في اسكندرية عارفين يعني وجهة نظري في البيدياتريك جينيتو يورينري انكولوجي. بس أنا بصراحة عندي 2 بيرز يعني في الانكولوجي سيرجيكال مانجمنت رهاب. يعني طبعا هيثم ما شاء الله يعني من الناس اللي عندهم very good experience in neuroblastoma management، مش بس neuroblastoma، كل البيدياتريك جينيتو يورينري تيومرز. واخويا الصغير الدكتور احمد فهمي اللي ابدع النهارده جدا في المحاضره الرهيبه دي. واحنا الحمد لله رب العالمين، انا بس احب انوه لكل الزملاء اللي موجودين انه احنا كان في طفره كبيره جدا جدا في اسكندريه في السيرجيكال مانجمنت وبيدياتريك جينيتو يورينري انكولوجيك بروبلمز من ايام استاذنا الدكتور احمد هانو ربنا يديله الصحه. انا بس احب انوه ان الشغلانه دي شغلانه عايزه ديديكيشن قوي جدا، وطبعا السيرجري is very technically challenging، انما بدون وجود تيومر بورد واضح، بدون وجود MDT، اعتقد انه القصه بتفقد يعني شق كبير جدا من الاوتكم اللي انت منتظره. فطبعا احنا يعني تعبنا جدا في السيرجري وفي الحالات الصعبه، وعيشنا حالات كتير قوي، لكن بصراحه كانت الطفره الكبيره مع وجود بدايه فكره التيومر بورد. التيومر بورد فرقت معانا كتير جدا، فهمتنا كونسبتس كتير. طبعا الشغل بتاع هيثم والشغل بتاع احمد وان شاء الله يعني يفضل كده. التكنيكال اسبيكت بتاع الويلمز والنيوروبلاستوما، انا ما بحبش النيوروبلاستوما، يعني انا بيرسونالي بشوف انه يعني النيوروبلاستوما دي من التيومرز الصعبه جدا، بالذات السنترالي لوكيتد تيومرز. احمد انا يعني بشكرك جدا على المحاضره، مجهود جبار. انا مبسوط جدا بالسيرجيكال تيبس اللي هم الفيو سلايدز في الاخر، بصراحه فيهم فيري ان ديبث سيرجيكال نوليدج اللي كلنا يعني بنحتاجها. انا بس يعني طول عمري عندي مشكله في اسكندريه، واعتقد هيثم واحمد ووليد عارفين انه البروبلم اوف ذا سمول بلو راوند سيل تيومر، في تيومرز اللي بتطلع في مكان يعني تمشي نيوروبلاستوما، تمشي رابدومايوساركوما، تمشي اوستيو اي حاجه، تمشي حتى even undifferentiated rare renal tumors. فطبعا انا would like احمد يكومنت على القصه دي، لان احنا we have faced so many cases بالمفهوم ده small blue round cell tumors. النقطه الثانيه طبعا احمد قالها الايمج ديفايند ريسك فاكتورز. للاسف احنا يعني دي وظيفه التيومر بورد، احنا اللي بناخد على كتافنا جدا ازاي نقرا السي تي. وطبعا في وضعنا في التيتشنج هوسبيتالز في المستشفيات الجامعيه ممكن سي تي يكون معمول بقاله شهرين، ممكن سي تي عبال الجراحه. يعني انا الكلام اللي اتقال محتاج فعلا ان الواحد لو هيشتغل بالذات النيوروبلاستوما هو عايزه الديديكيشن ده، عايزه طبعا ميديكال اونكولوجيست بيشتغل بيدياتريكس يفضل، بس محتاج بيدياتريك راديولوجيست ديديكيتد. انا اعتقد ان زملاء كتير في البيدياتريك راديولوجي الاي دي ار افس ما اعتقدش ان هم يعني يعرفوها يمكن بالتفصيل اللي قاله احمد. لكن لازم يبقى الحاله يبقى فيها ميتنج معاك الأونكولوجيست، معاك الراديولوجيست، ومعاك الباثولوجيست. الكلام ده أنا رأيي في غاية الأهمية. الحاجات اللي وقعنا فيها الإشاعات القديمة، أنا أتذكر وهيثم فاكر من الطفرات برضو اللي حصلت، كان عندنا يعني فيزيتنج بروفيسور باسكال، ودي طبعا غيرت فكرنا خلاص. مرة عملت مشكلة كبيرة مع هيثم، كان السي تي اللي محطوط على الفانوس الإشاعة تقريبا عدى عليه شهر ونص أو حاجة كده، ففوجئنا إنها الولد كان نام فرفضت، هي رفضت. وانا في ساعتها كنت مستغرب، انما بعد ما الواحد اشتغل اكتر واكتر وابتدى يفهم يعني ايه اونكولوجي ويعني ايه سيرجيكال اونكولوجي ويعني ايه ريسبونسبيلتي، بقينا بنحاول نغير المفهوم ده. وانا اتذكر يوميها ان هي رفضت تعمل الحاله بعد ما عرفت تاريخ الاشاعه اللي على الفانوس، واضطر استاذنا الدكتور احمد فهمي يخش يكملها. يعني ليسونز كتير. لكن انا برضه احمد احب بس لو عندك اي كومنت على السمول بلو راوند سيل تيومر دايليما. انت اتكلمت كويس قوي على السنترال تيومرز، انا مش شايف ان في حاجه مش واضحه بصراحه ما شاء الله. والحاجه الثانيه الديسيمينيتد ديزيز فروم ذا ستارت، لو تدينا كده ايديا ان هو سنترال تيومر وفي ديسيمينيشن يعني ميتاستاتيك ديزيز، يعني البدايه من اول ما نشوف الطفل كده هياخد سكه عباره عن ايه. والف شكر ليك تاني على المحاضره الجميله دي.
متشكر يا دكتور يوسف والله. بس يعني هو تاكيدا لكلام الدكتور محمد يوسف استاذنا، يمكن اهم نقط في اللي عايز اعمل عليها ستريس في الام دي تي، يعني مالتي ديسيبلينري تيم في المانجمنت في حالات النيوروبلاستوما. يعني احنا دورنا لوحده كجراحين مش هيبقى كافي، يعني زي ما الدكتور يوسف لازم بيبقى فيه حد بتاع بيدياتريك راديولوجي، في حد بيدياتريك باثولوجي، في انستيسيست يعني فاهم كويس في الحالات اللي زي كده. الجروب بتاع الميديكال اونكولوجي طبعا ده مهم جدا في الديسيجن ميكنج والريجولار ميتنج. يعني لازم يبقى في تيرشري ريفيرال سنتر، هاي فوليوم سنتر، عشان طبعا this is not easy operation which can be done in anywhere. يعني طبعا يمكن احنا في فتره من الفترات كان عندنا ممكن حالتين وثلاثه في الشهر، كنا بنشتغل حالات كثيره فعلا فتره من الفترات. وبالتالي يمكن دكتور محمد ودكتور هيثم عندهم خبره كبيره واشتغلنا حالات كثيره، فطبعا الخبره دي يمكن بتزيد مع الوقت ومع عدد الحالات اللي بتخش. بس يمكن اهم حاجه I should stress upon this should be done within the confinements of tertiary referral center with high volume of cases with a multidisciplinary team including pediatric urology, pediatric anesthesia, pediatric radiology, pediatric pathology. طبعا اهم حاجه ميديكال اونكولوجي هو اللي بيجايد كل البروسيس دي. النقطه برضو المهمه جدا يعني very important take home message I will want to stress upon is the role of surgery in cases of metastatic high risk neuroblastoma. There is still a role, and as was mentioned in the presentation, it improves the event-free survival. It has a benefit on the event-free survival, however, not on the overall survival, but still we have a role. And we don't need to remove all the tumor. We need to debulk the tumor as much as we can. And in high-risk tumors, there is radiotherapy, there is myeloablative radiochemotherapy, and the bone marrow transplantation. There is a lot of tools in your hands or in the hands of our colleagues in medical oncology to complete the treatments of the patients. So I think in every stage of neuroblastoma, surgery have a role even in advanced metastatic disease.
انا بسالك ليه؟ لانه انت لو تتذكر ان احنا كان عندنا كذا حاله سنترال وام ستيج ميتاستاتيك وبايوبسي واندكشن كيموثيرابي and there is no response on chemotherapy. فطبعا it seems انه في الوقت ده بيبقى فيه بوش جامد جدا من الانكولوجيست والفاميلي من الطفل انه يبقى فيه انترفنشن. فانت يعني النقطه دي how we are going to tackle this.
I still remember I still remember Yusuf, very hot debates and discussions between you and Dr. Haytham and other members in the unit about the resectability or the surgical benefits of achieving exposure in such metastatic disease. وكان بيبقى فيه حوار حامي وندرفول ديسكشنز كتيره كان عيان هيستفيد او مش هيستفيد، وطبعا زي ما حضرتك بتقول كان بيبقى فيه بوش للميديكال اونكولوجي، بس الليترشر ندرفول ايفيدنس بيز ميديسن بيقول ان there is a benefit from surgical resection even in metastatic disease, taking in mind that you have to know when to stop. يمكن كان في سلايد برضه من ضمن البرزنتيشن
وانت بصراحه قلتها very
patient
obvious.
life at risk or vital organ at risk such as the kidney.
الكيدنيز لازم نحافظ عليهم، وما ينفعش يعني عشان نطلع تيومر كومبليت اشيل معاه كيدني. دي مسج مهمه قوي، وما فيش اي مانع ان انا اريسكت 80-90% واسيب جزء بالزبط. يعني there is always يعني a window ان انا ابقى في السيف سايد. طبعا احيانا الحكايه دي بيبقى الواحد عنده شويه حماس انه يبقى موجود، لكن وطبعا الحاجه الثانيه اللي انا برضو شفتها في القسم انه لما يبقى في حاله زي كده سنترال وبتاع، قد ايه بتبقى كويسه جدا لما يبقى في two persons they work together. تفرق كتير وعارفين الابروتش، لانه انا طبعا الفيلد ده فيلد صعب. حتى اليونج اللي بيساعدونا اليونج كوليجز النواب والمعيدين بيبقى برضو الفيلد ده. فاتس فيري امبورتنت ان يبقى معاك انذر كوليج هو نوز يعني الاناتومي، يساعد كويس الديسكشن التراكشن الاكسبوجر. فهي is a matter of dedication. لكن شكرا يا احمد، ومش عارف اذا كان في اي اسئله تانية بقى. انا شايف برضو الدكتور هيثم
يوسف
في 6 حاجات اهي جديده مش عارف.
عبد الحليم احمد عبد الحليم انا هعمل له اميوت، كان عايز يسال
تمام.
احمد فهمي.
ازيك يا دكتور احمد، شكرا جزيلا على المحاضره الجميله، وشكرا للدكتور هيثم والدكتور يوسف. So the role of biopsy is debated or mainly abandoned for Wilms tumor. I'm asking about the role of biopsies for neuroblastoma. Do you get biopsies routinely, or if the imaging criteria are consistent with neuroblastoma, you can avoid biopsies? Sometimes, as Dr. Yusuf referred to, sometimes you have tumors in relation to the upper pool of the kidney. You don't know if it's a renal or adrenal origin. So, do you take biopsies routinely, or is it, or if the imaging criteria or the imaging characteristics are very suspicious for neuroblastoma, you would start chemotherapy right away? And also the other point, for older patients, the tumors become more differentiated, become like ganglioneuromas or ganglioneuroblastoma, and they look typically like neuroblastoma, and at the same time they don't respond as well to chemotherapy, so you would expose patients to chemotherapy without getting substantial reduction in the tumor size. So give us some highlights or some thoughts on biopsies for neuroblastoma, please.
تمام احمد، this is very important question اللي حضرتك بتساله ده. يعني يمكن احنا كنا بنتكلم طبعا المانجمنت. انا صوتي مسموع؟
تمام.
يا احمد.
Management should be according to the INRG staging اللي هو International Neuroblastoma Risk Group Stratification. فاحنا لو خدنا اول حاجه اللي هو العيان اللي هو عنده L1 اللي هو احنا بنتكلم على ان هو single anatomical region with no image defined risk factor. يعني معنى كده اللي انا العيان ده عشان احطه L1 لازم اكون اوريدي عملت له ايمجنج سواء سي تي او ام ار اي ومفيش image defined risk factor، وقلت ان العيان ده عنده localized tumor و easily resectable و I will go straight forward to surgery and this will be definitive and the mainstay of treatments and there is no need for chemotherapy and there is no need for biopsy. عيان عنده adrenal tumor والادرينال tumor دي confined ومفيش اي مشاكل ومفيش اي metastasis والmetastatic work up is negative, there is no need for biopsy and there is no need for preoperative chemotherapy or induction chemotherapy. لو بعد كده هنتكلم من اول L2 والM، العيانين دول عندهم image defined risk factor وعندهم metastasis، واغلبهم 80% من العيانين اللي عندهم نيوروبلاستوما عنده بون مارو انفولفمنت. فعشان كده to start with ما بنعملش biopsy from the original primary tumor او الميتاستاتيك سايت. انا بنعمل الاول bilateral bone marrow aspirate or biopsy 80% من الناس دول بيبقى كونكلوسيف، خلاص انت مش محتاج بعد كده ان انا ارجع اعمل العيان ده برايمري بايوبسي فروم ذا برايمري تيومر او الميتاستاتيك سايتس، وببتدي خلاص الاندكشن كيموثيرابي طبعا، لان العيانين دول زي ما اتفقنا ما بنعملهمش اب فرونت سيرجري، بنعمل اول الاندكشن كيموثيرابي 4 سايكلز، وبعد كده بنعمل السيرجري عشان بتمبروف الريزكتبيليتي وبتقلل الانسيدنس اوف انتر اوبرتيف كومبليكيشنز. فالعيانين دول اغلبهم بنكتفي بالبايلاترال بون مارو بايوبسي او اسبريشن. لو اللي هي نوت كونكلوسيف او نيجاتيف او ما لسه في حبه داتا عايزين نعرفها، الحاجات اللي هي التيومر بلويدي والميك ان امبليفيكيشنز، ساعات بنحتاج نعمل اللي هو البايوبسي من البرايمري سيرجيكال سايت. زمان كان بتتعمل بالاوبن سيرجري، يعني كنا بنشوف حالات جايه مفتوحه، عيان عنده نيوروبلاستوما وبطنه مفتوحه عشان عمل بايوبسي اكسيجنال بايوبسي. طبعا دلوقتي دي از اوبسليت، ما بتتعملش خالص، يا اما بيتعمل الترا ساوند او سي تي جايدد بايوبسي اللي بنسميها كور نيدل بايوبسي، وبتبقى بنستخدم 14 او 16 جوج نيدل، بتبقى سفيشنت لينس، وبتبقى نمبر اوف كورز من 6 ل 8، ده الماجيك نمبر اللي بيتكلموا عليه، يعني لان كان في ديبيت كام كور بايوبسي تقدر تاخدها. او ممكن في الحتت اللي هي بتبقى صعبه زي مثلا في البوستيريور ميدياستاينم عشان في الهارت وفي الميجر بلاد فيزلز، ممكن بنعملها كي هول سيرجري اللي هي سوراكوسكوبيك جايدد بايوبسي. لكن برضه هنرجع نقول ان هو البايوبسي from the primary site of the tumor او metastatic site is usually done after we do bilateral bone marrow biopsy، وتطلع نيجاتيف او نون كونكلوسيف، او التيشو مش اناف اللي انا اعرف الهيستولوجيكال او البيولوجيكال فيتشرز اوف ذا تيومر، فاي ريزورت تو بايوبسي. بالنسبه للنص الثاني من سؤال حضرتك دكتور احمد، اللي هو العيانين الاولدر ايج اللي هو بيبقى بريزنتد مور ديفرنشيتد فورم اوف ذا تيومر، اللي هو يا اما جانجليون نيوروما. جانجليون نيوروما ده بناين يعني اوريدي، يعني لو هو جانجليون نيوروما وبناين تيشوز وطبعا بروفن بالبايوبسي، طبعا ده هيبقى لازم بروفن بالبايوبسي، ده طبعا مش هنديله اندكشن كيموثيرابي، وايفن حتى الرول اوف سيرجري فيه از ديبيتابل انليس اللي هو عامل كومبريشن على فايتال ستراكشر. اللي ممكن نعمله حاجه زي كده افتكر اللي هو الانترميديت ديفرنشيتنج اللي هو بنسميه جانجليون نيوروبلاستوما، وده should be removed، وطبعا ده بيتعمل له biopsy from the primary sites of the tumor.
انا عندي كومنت. هو في التيبل الريسك ستراتيفيكيشن يا احمد، هو ده it seems ان هو بوست سيرجيكال، تالي مش كده؟ يعني
لا دكتور يوسف، ده اللي هو الاي ان ار جي ده بري اوبرتيف، اللي هو البوست
لا
سيرجيكال.
مش قصدي كده، انا قصدي التيبل الاخراني اللي انت حطيت فيه ال L1 وال L2 والام والام اس والايدج والان مايك،
ده كل ده بري اوبرتيف، كل ده بري اوبرتيف معتمد على الايمجنج اللي هو السي تي والام ار اي، لان انت بتعمل له اي ان ار جي ستيجنج بيزد على الايمج ديفايند ريسك فاكتور اللي هي ام سي تي ام ار اي، والحاجات الثانيه كلها بتبقى انت عارفها اوريدي من ايه، من البايوبسي. البايوبسي بقى سواء انت عاملها بون مارو بايوبسي.
ما انا بسالك لانه الان مايك امبليفيكيشن which is a
very
important part من البايوبسي of the tumor or from
بايوبسي اوف ذا بون مارو او التيومر. طبعا في الاول بيبقى البون مارو، لو البون مارو مش كونكلوسيف
so you do the end mic in the bone marrow
بون مارو
ولا في البايوبسي اوف ذا
السبع حاجات يا دكتور يوسف اللي هو اللي عباره عن الكلينيكال والبيولوجيكال فاكتورز اللي هي في التيبل دون، كل دي بري اوبرتيف. يعني هو يمكن اللي فرق بين الاي ان اس اس اللي هو الانترناشونال نيوروبلاستوما ستيجنج سيستم القديم اللي احنا كنا معتمدينه، ان ده كان لازم العيان يعمل عمليه عشان اشوف اللي هو حصل فيه كومبليت جروس اكسيجن ولا انكومبليت جروس اكسيجن، ولا في ليمف نودز على الاذر سايد، ولا في ميديان تيومر، ولا في ميتاستاسيس. العيان ده لازم يكون خلاص عمل عمليه، وطبعا يحللنا
بس التيبل يا احمد ده كان فيه على حسب ما اتذكر كان فيه differentiation parameters and
بالزبط.
differentiation it should be in the tumor so you did surgery or biopsy.
البايوبسي برضو من الايه، من البون مارو. يعني كل الحاجات دي يا دكتور يوسف انت لو حتى هتلاقي كمان اللي هو الادفانتج اوف الاي ان ار جي اللي هو ده بري اوبرتيف، اللي انت بتقدر تاخد الديسيجن وتبني البروجنوز بتاعك بري اوبرتيف بيفور اني اوبريشن بالنسبه
so differentiation and in mic amplification
والبلويدي والليفن كيو ابريشن، كل الحاجات دي كلها
they are all in the bone marrow
based on the biopsy اوف ذا بون مارو. لو البون مارو مش كونكلوسيف ما اقدرش اديك كل الداتا دي، يو ريزورت اللي انت تعمل بعد كده بايوبسي من الايه، من البرايمري تيومر.
انا بقول كده لانه زي ما انت قلت انه ال L1 which is a very straightforward surgical case you don't need to do anything. If you are satisfied, you will go in and get out the primary lesion nicely, and you do everything. You do the differentiation, pathology, histology, and enzymatic amplification. So فعشان كده تخيلت ان الجدول ده هو بوست سيرجيكال او اللي هو باثولوجيكال، يعني بعد التدخل. اوكي.
شكرا دكتور احمد. So to summarize, for L1 tumor you do primary resection. For M tumor or metastatic tumors you rely on bone marrow biopsies, but for L2 you would have to biopsy the primary tumor then.
This is fair enough. Yes.
And for the benign variants or the differentiated tumors, you would just rely on biopsies because some of these tumors may be very large. And I don't know if biopsy of such large tumor or needle biopsies would be sufficient to exclude malignancy completely, because some of these tumors may reach large size. So I don't know, do you feel comfortable leaving or observing these tumors without doing surgery based on biopsy results?
احمد بعد اذنك، احنا في اسكندريه بيقابلنا السيتويشن ده ساعات في large tumors, especially central tumors not responding to chemotherapy even after sometimes it is from the start in neuroblastoma, and after chemotherapy it gets more differentiated towards the benign side. وبالتالي it doesn't not respond more to chemotherapy. والبيوبسي بتطلع ganglioneuroma, and you cannot be sure that there is no foci of neuroblastoma active inside the mass. We discussed this issue several times, and we resorted sometimes to the use of the MIBG scan to solve this problem. MIBG scan sometimes will give hot areas inside this tumor, suggesting active tumor or active neuroblastoma inside the mass. And also there are some trials for the PET scan, for the use of the PET scan. Also to discover some of the active areas inside these large tumors, if they are present or not.
شكرا دكتور هيثم.
العفو يا احمد. احمد فهمي موجود. Can you comment on that يا احمد؟
معلش دكتور هيثم، I didn't follow the last part since I was changing.
احمد كنا بنتكلم على اليوز اوف MIBG سكان في حالات اللارج تيومرز اللي احنا مش يعني عايزين نتاكد اذا كان جواها في فوساي اوف اكتيف نيوروبلاستوما اور نوت.
Yes, MIBG scan is one of the most sensitive diagnostic markers for diagnosing of neuroblastoma because it is norepinephrine analog. It is uptaken and stored in neuroblastoma cells. So in 90% of patients with neuroblastoma, it gives hotspots or can delimit accurately neuroblastoma cells in 90% of the cases. And even in patients who are not MIBG avid, we can use PET CT scan, but not as initially imaging study.
تمام. احمد في سؤال على الهيموراجيك سيستايتس يا احمد اللي ممكن تيجي مع السايكلوفوسفامايد. لا وكمان مع I think cyclophosphamide treatment. How you manage hemorrhagic cystitis in those patients?
Maybe I'm not the best person to answer this question because hemorrhagic cystitis is frequently encountered among doctors with medical oncology subspecialty. Usually it is a tricky situation and it might be an unknowing complication. Usually I don't have a direct answer for patients with hemorrhagic cystitis. I remember I encountered 1 or 2 patients with this, but usually this is the domain of medical oncology colleagues. We usually give something like disinone, captons, or something like this, but I don't know if there is some sort of local therapy or installation treatments inside the bladder to minimize these complications or not.
Ahmed, I'm trying to remember the name of the drug, which is called Mesna or Mesna. I think.
Yes, I remember this from
you. Yeah.
Yes.
I think bladder irrigation sometimes with cold saline.
Heparin and local
in the mild cases, and Mesna, and also stoppage of the of the chemotherapeutic agent for a while can stop this hemorrhagic cystitis.
This is among the complications of chemotherapy and pelvic radiotherapy encountered in patients with pelvic tumors.
دكتور احمد شومان بعد بيقول لك وكمان الالم.
الالم طبعا ده يعني معروف بالنسبه لنا في الحالات اللي بتاعت البليدنج طبعا الالمونيوم هيدروكسيد.
احمد المشكله احمد ساعات بتبقى في النيوروبلاستوما. احنا عاملين نقول ان احنا we can leave a part of the tumor around the vessels, we can leave a part of the tumor around the renal pedicle or around the superior mesenteric or around the celiac trunk. Our problem during surgery is when to stop to avoid injuring this vessel and when to decide that at that level I can leave that part, because in many of the instances you cannot see even the vessel or the origin.
I totally agree دكتور هيثم. يعني حضرتك النقطه اللي حضرتك بتقولها دي نقطه مهمه جدا. يعني neuroblastoma surgery is not surgery for fainted heart and for those who are not experienced with vascular anatomy and vascular surgery and oncological surgery, because you need to be very familiar. احنا كنا بنقول برضه من principles we have to stick to. You have to get very familiarity with the anatomy. And sometimes it's even difficult because the anatomy is distorted, because the tumor displays some of the vessels, the tumors encase vessels, and make even identification of the normal anatomy very difficult even for the experienced surgeon. So you have to be wise enough, and so you have to use your experience when to stop and when there is a danger of inflicting a damage or major injury to vascular structures such as celiac branch or the superior mesenteric artery or the porta hepatis, which will leave the patients with unrecoverable and major disaster and will not benefit. So there is a balance which we have to make. Patients with high risk advanced stage median neuroblastoma have to do surgery, but you have to know your limits. You have to know when to stop. Whenever I remember the last case in which I have operated upon neuroblastoma, دكتور يوسف كان واقف ظهري وكل شويه يفرملني وكنا ماشيين على مش عارف الدكتور يوسف يفتكر ولا لا. كان حاله فيري ديفيكالت برضه ماسكه في كل الميجر برانشز اوف ذا اورتا والاي بي سي، وبرضه زي ما كان الدكتور يوسف بيقول الانثوزيازم ساعات بيبوش يو تو جو فيرسر، وتبقى انت عايز برضه انت تبنفيت البيشنتس من العمليه وتشيل as much as you can.
عايز اسال هيثم بقى بنقطع كلامك. هو انا عارف ان انت قلت الابروتش دي انسيجنال ابروتش، بس انا متهيألي هيثم بيعمل another generous incision as far as I remember. يعني هو مش بيعمل subcostal بس ولا بيعمل thoraco abdominal ولا اللي هو البايلاترال شيب. لا انا اعتقد ان هيثم is doing something مختلف شويه، ولا ايه يا هيثم؟
لا في الحقيقه يا يوسف انا بعمل ترانسفيرس ابر ابدومينال زي ما احمد بيقول. بس انا عايز اقول حاجه في الموضوع بتاع الفيسلز ده. احنا من الاول طبعا لازم يبقى في بلان واضحه للجراح وهو داخل في النيوروبلاستوما، يبقى شايف كويس قوي بتاع الاشعه السي تي، يدور على الفيسلز اللي جنب الماس، يبقى عارف الاماكن اللي الفيسلز فيها اكسبوزد ومش متغطيه او encased totally by the mass، عشان يبدا السيرجري بتاعته بان هو يعمل identification of the vessels at risk ويجيبهم من السايتس اللي هم exposed فيها ومش encased by the tumor، ويبقى شايفهم كويس جدا في الاول بعيد عن الماس، وبعدين ويبقى محدد مين الفيسلز اللي totally encased by the tumor ومين الفيسلز اللي partially encased by the tumors ومين الفيسلز اللي just attached to the tumor. كويس زي ما احمد قال. وبعدين يبدا من الديسكشن بتاعه من الفيسلز away from the mass ويبدا يشتغل لغايه ما يبدا يدخل على الماس. بالمنظر ده هيبقى عنده good exposure للاريا around the tumor، ويبقى عارف الاماكن اللي ممكن يطلع منها الفيسلز اللي داخله جوه الماس، ويبدا يجيب الاوريجنز بتاعتهم. يعني مثلا انا لما ببقى خايف على الرينال بيديكل معدي جوه ماس نيوروبلاستوما، والنيوروبلاستوما دي anterior to the IVC for example، او اسف posterior to the IVC، والرايت رينال ارتري داخل جوه الماس دي قبل ما يدخل في الرايت كيدني، فاول حاجه بعملها ان انا بدخل على الاي في سي، اسلك الانتيريور سيرفيس اوف ذا اي في سي، وايدنتيفاي الليفت رينال فين والرايت رينال فين، وعلق الليفت رينال فين وعلق الرايت رينال فين. انا ماليش دعوه بالماس خالص لغايه دلوقتي. وبعدين اروح داخل على الاورطه، مسلك الانتروميديال سيرفيس اوف ذا اورطه، ومطلع الاوريجين بتاع الرايت رينال ارتري فروم ذا اورتا في الانتر اورتو كيفال ريجون، تحت الليفل بتاع الليفت رينال فين. الاريا دي خلاص هي الماس اصلا تحت الاي في سي. الرايت رينال ارتري ده داخل جوه الماس، بس الاوريجين بتاعه عند الاورتا از كلير، فانا ماليش دعوه بالماس خالص، انا اجيب الاوريجين بتاعه من عند الاورتا.
طب
وبعدين افضل
بقى
ما هو اللامبر ارتريز دول
اللي هم موجودين ظهر الاي في سي، وانت
والحقيقه واللامبر فينز دول كتير قوي يا محمد بيحصل فيهم. الاول بس انا مركز ليه على رينال ارتري عشان تو سيف ذا كيدني، وبعدين رينال ارتري ده تمشي معاه، وبعدين تستخدم الباي فالفنج تكنيك اللي احمد قال عليه، ان انت طول ما انت ماشي بتحط الكلامب ده ما بين الرايت رينال ارتري وما بين الايه التيومر، وبتقطع عليه فبتكسبوز مور، ثم تيجي يمين وشمال الارتري، بتفصل يمين وشمال الارتري، فتبدا عامل اكسبوجر كويس لغايه ما تسلك الارتري تماما فروم انسايد ذا تيومر، ويبقى معاك رينال فين من الاول. بقت كده الماس ورا الاي في سي. ايه بقى اللي لسه ماسك في الماس؟ هتبقى ماسكه في البوستيريور سيرفيس اوف ذا اي في سي، هتبقى ماسكه في اللامبر فينز اللي على البوستيريور سيرفيس. يس، lumbar veins في الحقيقه sometimes you can see them and sometimes you will cut them. كويس؟ يعني sometimes during dissection هتقدر تشوفهم، و sometimes هتلاقي اتقطعوا بقى في breach او بقى في foramen inside the IVC. You can take it suture with Prolene. يعني yes you will suture it. كويس؟
suture it.
Yes. دول مقدور عليهم، انما المشكله في المين فيسلز اللي لو حصل فيهم انجري، الكدني مثلا هتبقى خلاص بقت اسكيميك، you will remove it. كويس؟ او ممكن حتى تبقى اسكيميك وانت ما خدتش بالك انك ربطت رينال ارتري، وشفنا حالات
صح، وتلاقيها في السي تي اللي بوست اوبراتيف، وتلاقيها في السي تي بعد كده انها نون برفيوزد.
بالظبط يا يوسف. انا احمد وضح البوينتس دي كويس، بس انا حابب ان اللي بيشتغل نيوروبلاستوما يبقى عنده بلان how to tackle the vessels away from the mass first.
احمد برضو قال حاجه يا هيثم، و I think we need، لان انا يعني ان انت توصل للاوريجين اوف ذا aorta from the crus، يعني this is a very high area. انا مش عارف we usually go to this very high level.
انا ما عملتهاش انا ما عملتهاش، يعني ما وصلتش للاوريجين بتاع الاورطه في الحقيقه من الكراس في الاريا دي. انا دايما بجيب الاورطه من تحت من عند البايفوركيشن بتاع الايلياكس، وافضل طالع معاه ستيب باي ستيب لغايه المكان اللي انا عايزه يعني. لكن
يعني
في الحقيقه
انت you should identify the superior mesenteric artery، ومتهيألي ان احنا with this level usually we don't need to go higher than this. ما اعرفش يا احمد رايك ايه؟
هو على اساس الليفل بتاع التيومر فين يا يوسف ومحوط مين. يعني لو الليفل بتاع التيومر تحت الليفل بتاع السوبيريور ميزنتريك ارتري، انا مش هاجي من الحته، انا هاجي من تحت لغايه ما اوصل للماس واسلكه. انما في حالات ساعات الليفل بتاع الماس بيبقى واخد كمان السوبيريور ميزنتريك
فوق السوبيريور،
فانت هتمشي على الاورطه بالراحه لغايه ما هتلاقي الاوريجين بتاع السوبيريور ميزنتريك ارتري، وفي الحقيقه بيبقى فيري نارو وفيري شورت. ولو الماس محوطاه المانوفرابيلتي اوف ذا ماس لوحدها، لو انت داخل سب فيشل او سب انتمال زي ما احمد بيقول، لو حركت الماس يمين او شمال جامد هي ممكن تقطعه اصلا من الاورطه. and I have seen this before.
This is a disastrous problem.
Yes, I have seen this before. يعني in one case we have seen the superior mesenteric artery avulsed from the aorta. كويس؟ وطبعا it's a major catastrophe. You need someone, a vascular surgeon with you to do the reimplantation again of this artery, and it is not easy. It is not easy in the situation of a large tumor still present in the abdomen around the.
ده بيهايلايت قد ايه البري اوبراتيف بلاننج والايمج ديفايند ريسك فاكتورز والفيسل افكشن قد ايه مهمه. ما فيش سيرجري للنيوروبلاستوما من غير يعني الماكسيمم يعني knowing of all these data قبل ما تخش. تمام. اوكي.
احمد عايز تكومنت على حاجه؟
لا والله يعني حضرتك يمكن اوجزت يعني بالكومنت الاخير ده فعلا اللي هو يعني البري اوبراتيف بلاننج والرود مابينج والفاميلاريتي والستادي بتاع الفاسكولار اناتومي والبروكسيمال والديستال كنترول بتاع الفيزلز بيفور تاكلينج اور اتاكينج البرايمري تيومر، لان ساعات بتبقى تيمتنج واحنا كنا في الاول يمكن بنفكر تشوف التيومر كده ايدك تاكلك على التيومر وتبتدي تسلك حواليه، لكن فعلا ممكن you come across major vascular branches or vessels which will cause accidental vascular injury يعني which might endanger vital structures اهمها طبعا الكدني. واحنا برضو من ضمن المسجز اللي يمكن ستريس عليها في المحاضره دي you try to preserve and keep all vital structures especially the kidney عشان العيان ده بعد كده هياخد كيموثيرابي وهيعمل مايلو ابليتيف كيموثيرابي، فطبعا عايزين العيان ده as much as can have both kidneys viable من غير اي مشاكل ومن غير حتى unrecognized ischemia او اي مشاكل في القصه.
شكرا يا احمد وشكرا دكتور يوسف وشكرا لحضراتكم
شكرا يا احمد
جميعا.
وشكرا لكم جميعا.
شكرا.
ولقائنا يوم الجمعه ان شاء الله.
احب انوه تاني عن محاضره يوم الجمعه ان شاء الله الساعه 9 بالليل دكتور احمد عبد الحليم مانجمنت اوف مايلو ديسبليجيا ان شاء الله باذن الله، في انتظاركم ان شاء الله. شكرا.
تصبحوا على خير.
تصبحوا على خير.